So this is the second in the third planned webinar from the recent North American Region Union Conference that took place in Vancouver. I'm very excited to be hosting this session with two other of our presenters. This is two talks within the theme of what is hot in treatment, differentiation, and individualization. And these talks fell under the ECIA session, which is our Early Career Investigators Award session. So we identify and award an Early Career Investigator Award, and then they get to plan subsequent sessions on what has stimulated their interest and is innovative and new in our TB space. Before we begin, I'll introduce myself. My name is Dr. Rachel Dwillow. I'm an assistant professor of pediatrics at the University of Manitoba in Canada. And I will now turn it over to Dr. Jonathan Campbell of McGill University, who's going to introduce both himself and our first speaker today.
Thanks, Rachel, for the introduction. I'm co-moderating this session with Rubandi, who will introduce herself and the next speaker after our first talk. I'm an assistant professor in the Department of Medicine at McGill and associate director of the TB Center there. I didn't have the opportunity to attend NAR despite planning it this year, so I'm especially grateful to UCSF, Curry, and the whole NAR team to put on these webinar sessions. It's my pleasure to introduce Dr. Rada Savage, who's going to be giving our first talk. She's a professor at UCSF and program director of their Clinical Pharmacology and Therapeutics Fellowship, co-vice dean of the Graduate Pharmacy Education Programs, associate director of UCSF Center for TB, and a Chan Zuckerberg BioHub investigator. She applies innovative quantitative and systems pharmacology methods to propose optimized and precision dosing strategies, data-driven risk stratification algorithms, and inspires new clinical simulation tools across the infectious disease landscape. And this really is what this kind of work inspired me to ask Rada to give a talk in the session earlier. And she did exactly that at NAR, and I'm delighted she agreed to run it back at this webinar for all of you. Over to you, Rada.
Thank you, Jonathan, and thank you everyone for joining today and giving me this opportunity to repeat our talk. It was a really fun session at NAR, which I've enjoyed. So yeah, I will share with you today what we've kind of learned about treatment certification over like a more than decade of the work, and what kind of we consider to be hot and to be interesting and hopefully applicable to the field. So with that, I will start with this triangle that I like to talk about. Like when we think about treating TB, clearly we are doing a lot of work to diagnose TB and to do the right diagnosis. And here, like we really are thinking about if bacteria has changed in any way, and if bacteria is resistant or kind of harder to treat, right? So that we can apply right treatments and right drug combinations. I think we do a really nice job on diagnosing and understanding what bacteria are we treating. However, when it comes to a patient, we kind of do still treat patients as the same, and we do kind of apply one size fit all approach, and we do not really differentiate patients based on their pathological features and how hard or easy to treat they are. And I think that's really the part of innovation that I would like to go to. Clearly, we would like to apply the right treatment to the right patient for the right diagnosis. And by right treatment, I often consider not only the right drug combinations, but also right duration, because some patients can go shorter, some patients need longer. And within that duration also, there's like a lot of discussion about what the optimal doses are of all of these treatments. So it's been a quite complex triangle to solve, but nevertheless, that is something we definitely can do. So I will just go through several high-level kind of learnings about the fact if patients are the same or patients are different. And I will start first with really understanding what we have learned from many phase 3 clinical trials that we ran over the last decade. And on our side, we have integrated data from all major phase 3 trials that have happened in drug-sensitive TB, and that created this database of almost 7,000 patients with drug-sensitive TB. And in all of these trials, clearly we had a control arm because these are randomized trials, and then we had interventional treatments. And we know that only one of those treatments, study 31, was successful when it came to treating patients shorter. However, what we have learned, just if we focus on HRZE, so this is basically, our old standard of care that we use for all the patients. We have learned that if we're trying to kind of identify a risk of a patient to fail to succeed the treatment, to fail the treatment, we've learned that the patients actually are carrying different risk for treatment failure or treatment relapse. And basically this risk, which I'm showing right now here as a distribution, as a risk score, can be shown in much more friendly way, which is really understanding for each patient what is really the true optimal treatment duration if they're treated with HRZE. So that can be really inverted and ask the question, what is the optimal duration for each patient based on their risk score? And we've kind of published in the past on this specific topic. And one thing we have learned from this work, integrated data trials, phase 3 clinical trials, is that patients need different duration. And despite that fact, we still treat patients the same. We treat them for 6 months and hoping for 95% of the cure in clinical trials. So I think that's first learning. Even with HRZE, we can do better. We can select patients that can go shorter. We can select patients that they need longer based on certain features, which I will come to in a moment. So next thing we've learned, so this is one first thing we learned from clinical trials, that even on HRZE, we can do much better than we're doing right now. The second lesson, what we have learned from drug-sensitive phase 3 trials, is that majority of the phase 3 trials, they have failed not because these regimens were not effective in all patients. Phase 3 trials have failed because majority of the novel regimens that we have tested in phase 3 did really well, what we called an easy-to-treat phenotype. And here on this plot, I'm showing you 5 different regimens. Orange is in control. The green is the only successful regimen, which is HBZM regimen, and 3 other regimens are various regimens from, I think, Premox and study 31. And you can see when you compare these regimens, the efficacy of these regimens in what we call easy-to-treat phenotype, all of these regimens are doing really well. So basically, this is really telling us that any of these 4-month regimen would be really a good regimen for easy-to-treat phenotype. However, when you look in the hard-to-treat phenotype, this is really where regimens differentiate. And we can see only that the green regimen, which is HBZM regimen, is approaching success of the control regimen, which is orange, and all other 3 regimens have not done really well. So I think the outcome of these trials was that we did not have successful trials. So sadly, we don't have any of these regimens recommended for easy-to-treat patients. Despite the fact that these regimens are doing really well. So the way I think about these things is that really, even now, we have, for majority of the patients, which are easy to treat, we do have regimens that can be used, and these patients can be treated for 4 months. And this doesn't have to be HBZM regimen. This can also be other regimens that we have studied in clinical trials. So again, learning number 2 is that we already have shorter regimens for easier to treat patients. However, these are not approved, these are not recommended because the entire clinical trial was not successful. Then the next thing we have learned from study 31, here I'm showing you the work from study 31, which pretty much says the same thing, that if you look at the easier to treat phenotype, There was no really difference between control or short arm that have failed or short arm that did not, they were successful, which is on the left. And this is the truth both in the context of low exposure and high exposure, rifamycin exposure. However, when we look at the hard to treat patients, I think one thing we've learned here that this differentiation between regimens become very, very pronounced in the context of low exposure. So what this really means is that in context of high rifampin exposure, again, there was no differentiation between different regimens. So, for example, high intensity, more intensive treatments, they can also overcome this phenotype effect. Again, for us to be able to implement this and to know, we would need to know the dry exposures, which is really hard. But I think the learning here is really that intense treatment and accurate treatment can also overcome the phenotype effect and can improve the cure rates. So I think this is a summary from drug-sensitive trials. I want to now switch and talk a little bit about drug-resistant databases that we've kind of asked the same question. And here I'm just showing you one of the databases we worked with together with Jonathan and McGill team. Basically, we combined the data from the programs outcome data in drug-resistant population, and also the data in clinical trials in drug-resistant population, specifically focusing on BPAL regimen. And we asked the same question: can we identify phenotype? Are there patients that do actually better or worse based on their phenotype on some of these regimens? And really the findings were the same. Again, if we stratify patients by phenotype, here I'm showing you the program data, which are adjusted for the treatments. And I'm not going into treatments here. So you just kind of need to know that different treatments were adjusted for, and really the focus is on phenotype. So really asking the question, when patients are treated with the same regimens, we can see that success rates of these treatments is differentiated by phenotype. Again, the hard to treat or high risk patients, they do the worst, while the low risk patients, they do the best, and which are shown in the blue. If we're just trying to predict treatment success based on baseline characteristics, we can achieve a ROC of 0.8, which is quite impressive, based on just kind of baseline characteristics. So this really telling us that even at baseline, we kind of know quite well what the outcome of the treatment would be for a patient based on their phenotypes. When we look in the clinical trials, so now I'm showing you the results from NIPS and ZNIPS and TB Practical, again, focusing on BPAL regimen, and again, stratifying patients only based on baseline characteristics in low and medium or high phenotype. You can see on the left that, again, yellow, which is medium and high risk phenotype, they're the patients that do worse on BPAL regimen. And then if we are able to also adjust for culture status, which is kind of on treatment and harder to get, we can see that separation becomes even more pronounced. So I think, there's a lot of evidence across programs, across DS, across rifampin-resistant TB, across clinical trials that kind of is pointing out as to this phenotype effect, which now I will kind of just introduce. And what we have learned across this work, which is again over more than a decade, we've learned that in order to that there's certain features that always show up in any trial analysis or any program analysis. And they're all equally important to be introduced in the phenotype. So for example, so these are the 5 features that they're simple features that clearly can be implemented in clinic, and we have to kind of account, or we have to include the measurement of arterial burden, and this can be done either using like a old-fashioned tool such as smear, or something more novel like TTP or Gene Expert, but we have to have some kind of indication of what arterial burden is at the baseline. We have to have assessment of lung damage based on chest x-rays. And by lung damage, I say lung damage because really we've seen that different features from the chest x-rays are predictive, and they really kind of point out to cavity size and also extent of disease in the lungs are the most predictive features. So one of these two we would like to use in risk stratification algorithm. Nutrition and BMI, I think, is like a very constant factor that shows up. So malnutrition, low, which really is associated with low immune system, and just other factors, but it's a really good indicator of the risk score. Various comorbidities. Clearly, in the past, we always just looked into HIV, but I think now we also are seeing other comorbidities like drug abuse and drug abuse and diabetes. And there are some demographics that, again, are very constant features. Women just always do better than men when it comes to treatment outcomes, and I don't have explanation for that. And clearly the age is a very important one, where we see higher risk for very old people and also higher risk for adolescents and very young kids. So in general, I think we have to think about these 5 features when we talk about the risk for treatment failures. So now I also just wanted to touch base clearly in pediatrics, because that's another area where we always keep hearing that kids do well and kids are fine. However, we looked into this again, IPDMA. From the programs, we had database of more than 20,000 children from all around the world. In this database, 14% of the kids died and from TB, and 4% failed the treatment. And we also asked the question if what are the drivers of these outcomes in these program databases. And just to show you geographic location of these kids, so really the data came from all over the world, clearly mostly from India and South Africa, but there were representations from all other countries, from Eastern Europe, from Asia, from other places in the world. So this is the most diverse database that we ever had. And even in this pediatric database, when we kind of asked the question, what are the drivers, mortality and TB treatment failures, we're kind of getting the same features, which is always kind of fascinating. In this case, age is on the other spectrum. So very young children, they do worse. Boys do the worst. And then we have the sex effect even in children, pulmonary disease, smear positive, and also HIV positive kids. Again, the same type of features. So I would say like these features are very consistent, no matter if you're a child or if you're a patient, if you're DS or if you're DR, TB, and that's basically, I think, we have sufficient evidence to not to be kind of asking this question yet again. So now the question is like, okay, if we have this evidence, so what are the barriers? Why don't we do better down the road? And I wanted kind of to focus on 2 different major barriers that we kind of accounted for. I think the major barrier why we don't do stratified treatments is that a handful of prospective clinical trials that have tried to shorten the treatment based on phenotype, these trials have actually, they were not successful. So we tried, because this is the completely highest level evidence, randomized clinical trials. And I think one thing we've learned, I'm going to go through these specific trials, but I think one thing we learned is that we need certification criteria to be refined, because trials did not fail because the idea was not a good idea. It's just that potentially the certification criteria and the risk score is something that was not nailed down. And I will kind of first start with showing you, this is the first trial that tried to shorten treatment duration in adults with non-cavitary TB. This was a UM1 trial run by John Johnson in Uganda back in 2001. And in this specific trial, the phenotype was HIV uninfected non-cavitary patients that have converted cultures by 2 months. So these were the patients that were stopped at 4 months. And these were the results of this trial, which clearly showed that it was not enough. So these patients did not do so well. So one analysis we've done with this trial data in John Johnson team was later, like a decade after this trial, and we pretty much reanalyzed the same trial, and we used this study as validation of our kind of a risk score algorithm, and we have learned that the reason why that trial did not really do well, and why these patients actually, even if they were non-cavitary and non-HIV, and they converted their cultures at month 2, this trial specifically included very high bacillary burden at the baseline. And that was the major risk factor for these failures that have seen in month 4. So going back, thinking about the phenotype, so the phenotype did not include baseline burden. And as I said earlier, that's one of the main factors that we have to include. So when we reanalyze and we kind of took smear 3 out of the trial, every single patient actually did well. So again, that's why I'm saying that phenotype can be refined, and hopefully we can have better results. The other trial, I think, which is much newer trial, and I think much more elaborate and eloquent trial, was PREDICT TB trial. So this was a trial run by Cliff Berry based on decades of work for biomarkers to predict TB treatment duration. And in this specific trial, which enrolled 960 patients, basically the phenotype was determined using a PET-CT at 1 month compared to baseline. So they were looking for specific improvement in PET-CT, and they were looking for certain markers of gene expert at 4 months and adherence. So this was kind of a phenotype characterization, these factors. And in this trial, basically, if patients met these criteria, patients would be stopped at 4 months. Sadly, that also did not work, and many more patients actually have failed. So again, we have not reanalyzed this trial. I don't think it's still public out there. These are clinicaltrial.gov results, but nevertheless, we do hypothesize that clearly that this phenotype, again, scoring might be refined, and we still have 85% of patients doing really well with 4-month regimen, and that sort of can improve these results. So these are 2 trials that actually could not show certification works, and I think going forward we have some prospective trials which are very innovative. And this is one of these trials, Spectra TB or A5414 trial. And basically what this trial is trying to do to generate evidence is to classify patients on high risk and low risk. And in this case, phenotype will be based on chest X-ray, bacterial burden, BMI, and HIV. So I think these are all features we think are important. And basically what this trial will try is, if you're low risk, basically these patients will be assigned different treatment duration, anything from 10 weeks to 18 weeks. And the goal of this trial is to really understand how shorter you can go in low-risk patients, rather than kind of determining a priori what is the optimal short duration for these patients. So I think this is a very trial that will let us learn a lot, how shorter we can go in low-risk population. High-risk population will actually receive 6 months of HPZM regimen. So this is our current 4-month regimen, but nevertheless, we've learned that these high-risk people, they still need longer treatment, and they will be compared to a control arm. So we do anticipate this trial will be very informative for stratified medicine down the road. We have another trial, which is a PRISM TB trial, US AID funded, defunded, and funded again. So we'll really see what's going to happen with this trial in the future. But nevertheless, it's kind of the same principle. Phenotype is based on chest X-ray, burden, BMI, HIV. And then in this specific trial, which is in rifampin-resistant TB, intervention will be BPALM, where easier to treat patients will receive 13 weeks, and harder to treat patients will receive 26 weeks. And that will be compared to control, and that will be also compared to one-size-fits-all 4-month arm of BPALM. Again, we will learn a lot about potential. One success story, I feel like in adults we were not successful when it comes to stratified medicine, but a really beautiful, successful story is SHINE trial. which did show that we can shorten treatments for non-severe TB in African Indian children. And basically, in pediatrics, I think they got this phenotype correctly. And that is, I think, really the only evidence we do have based on randomized clinical trials. However, I think so. Even if this trial has been successful, it's very hard to implement the trial, and that will kind of I want to switch now gears and talk about other barriers. So one barrier is you have to have clinical trial evidence for these things to become part of guidelines. But also I think the other bigger barrier is really the requirement for ability to do risk stratification at the baseline. And one thing that we've kind of learned that over the years is that for us to have a very good risk stratification score, we have to have chest X-ray, really without including pathological features or cavity size or extent from chest X-ray. We cannot really do a good job when it comes to stratification. And that has also shown through clinical trials and through other things. So and this is really the second barrier, which is implementation barrier. If we cannot implement chest X-ray because chest X-ray does not exist in the field, and that is something we usually get feedback from programs. We don't have chest X-rays in the field. We cannot do that, and that's one of the main barriers also for the SHINE to be implemented. So I think we're really thinking forward, like how can we overcome that barrier? And since the title of this session was "What's Hot in Stratification," I personally thought that some new technologies that can replace chest X-ray to give us information from chest X-ray for us to be able to implement stratification algorithm is very, very promising. And these were some new data that came out of UCSF and were presented to TB Science in Bali, Indonesia, where they've looked of ability of vibroacoustics signatures to predict chest X-ray readouts. And I will share a few slides on this, because if we are able to replace chest X-ray with this technology, which is non-invasive, doesn't require cold chain, does not require medical professional, then I think implementation of stratified medicine becomes really a reality. There's really no major barriers that cannot be overcome. So, so this specific technology, really what it does, it's kind of collects passive infrasonic to ultrasonic biosignals. So this is physics. This is kind of beyond even my head. But basically, it's a super stethoscope that's able to capture biosignals of obstruction within between lung. And what it's able to do is to differentiate normal versus abnormal lung function. It's kind of easy to use, it's handheld device, and can be also used for cheap screening and triage of presumptive TB. I mean, to start with, this device was part of diagnostics network, which we partnered, and then we asked the question, can we actually use this type of signatures for disease severity? And that was really the project that Tessa looked into. So, so basically, what R2D2 network has done, they've kind of enrolled a study population older than 12 years out of 5 countries, and disease severity outcome was read out from chest X-ray. And basically, the thing we wanted to predict was extensive disease in chest X-ray, because that's one of the major features that we require for treatment stratification. The technology itself, it takes around, I think, 3 minutes to collect these data across 6 auscultation points. They're shown right here. And just kind of to show you like some raw data, you can see on the left side is like it's a wave from non-extensive disease patient, and on the right you can see the sound wave from patients with extensive disease. So there's a clear difference, and all of these numbers, they kind of show what you hear at different parts of these auscultation points. So overall, there was 1346 participants that were enrolled out of 5 countries. So very diverse population, very diverse in terms of age. There were patients living with HIV. So I think really representative of our usual TB population. And the team here at UCSF built algorithms to really kind of connect these sound waves and to ask the question, if we build MLAI algorithms, how well we can predict extent of the disease. And this is just a summary for those who are interested in the method itself. So again, just like a visual thing, I'm a visual person, and I like to kind of, just see an example, how these kind of data would look like if you have TB, but you don't have extensive disease, which is on the left, versus the data that come from the patients that do have extensive disease, which is shown on the right. And this is kind of a model prediction. And one, I think, really promising results was that just based on this 3-minute test, this initial study, pilot study, which was quite diverse and quite large, but it had a really great sensitivity specificity when it comes to just telling us who has a very severe disease. Clearly, like, if this can replace chest X-ray and give us this information, because this information that we need to put in the risk stratification algorithms, we will be able actually to implement stratified medicine in a real world setting, even when chest X-rays are not available. So with that, I just wanted to summarize a few key points. I think in general, stratified medicine for TB care, looking in more than 35,000 patients up to now, is really telling us. So we've definitely can reduce duration, and by reducing duration, we're reducing toxicity, reducing the cost. I mean, I don't need to convince this audience why shortening duration will be beneficial, and by not compromising efficacy, which is the most important thing. So I think really for severe disease, we might need longer treatments, but around 3/4 of the patients can be already now treated with shorter treatments, and that's something we would like to strive towards. It's definitely more patient-centered approach. Again, most importantly, we do want to enhance cure rates for severe TB, because this is where we have the most bad outcomes, including mortality and including relapses. And I think it's really showcasing the alternative to one-size-fits-all that we right have now. It's definitely feasible, and with these new diagnostics or these other type of things that might come down the road, we need to think also about how to implement this in the field. So with that, I just acknowledge my team and many funders and many collaborators, and also to acknowledge R2D2 network that kind of carried forward the other piece of work. Thank you.
Awesome. Thanks so much, Rada. Appreciate it. So we do have a few minutes for questions. I think see Andy Vernon's got his hand up. So I'll let you go first, Andy.
Thank you. Thank you, Jonathan. Thank you very much, Rada. Very nice presentation. What happened to predict TB? Why didn't it work? Because they had both a measure of burden and a measure of extent, and these were, of course, they didn't have PK, which would likely have played an important role in terms of shortening. It didn't in the 6-month arm in study 31, but that's because it was 6 months. But when you shorten is when PK seems to become extremely important. Do you think there was anything else that was missing?
Yeah, well, that's a great question, and I haven't looked at the data. We've looked at the trial that preceded predict TB, but we still didn't get predict TB data, which we will eventually. And I really don't want to say anything wrong. And I'm sure that Cliff and the team thought much about this trial, but I do think a couple of things. So I think there are a couple of things that are different. They've said they wanted to see certain improvement on PET-CT, and the way how from baseline to month 1. So they have kind of certain criteria which they thought is promising. So I think that they might have gotten that wrong. So it is really based on not where you start, but how much you improve over month 1. And I do think like where you start is very, very determinant of like what brought you to that start to start with. Because there are things that why are you starting very severe is that probably your immunity is not good enough, and like there are reasons why some patients are more severe to start with. And so I think they looked into that initial response, and the other thing they looked in is a gene expert at month 4. And you can argue, like, again, you can argue that, gene expert is DNA. It's not a real, it's not, I don't really know what is, telling us. It can be from dead bug. So again, it's like, they require gene expert to be negative by month 4. And again, clearly stratification criteria was not good enough. But nevertheless, they still have 85% of the cure. So I do think it's worth looking back. And I know that Cliff always says that there's some features are called the dirty cavities. He called them dirty cavities, where actually on PET-CT he could point out like certain features on the cavity in the patients that have failed. But this is all like just based on what I know from talking to him. But we will do the analysis down the road compared to other trials.
Thank you.
Yeah, I can read. Yeah, I think there's like a one about for spectra for PRISM. So the metric we're using for chest X-ray severity, it's extent of disease. Basically, I think based on and this great work at TBTC back there, really we're looking at the area of lung affected by disease, and the reason for that is just we always find that that's a very, very predictive metrics, even more predictive than cavity or cavity size. I think we are using for PRISM extent of the disease. And then, okay, so for PRISM TB, I think that was public news first. We got a letter that we were fully defunded. And I think the funding now has been reinstated, but we are still trying to understand the limits. So we'll see where we will land, but I think we have USAID funding is not completely dead for PRISM. So we'll keep going.
There's one more question in the chat. I think from Janice, which I'll summarize because I also have, I guess I had a similar question that I had lined up in case we ran out. So I think what Janice is saying is that they try and individualize treatment, mortality is low, relapse is low, but duration's a problem because they cannot get shorter treatment durations because of side effects. And if I can take the liberty of moderating here and add on to that, so we have all of these 4-month regimens that, you've shown have excellent outcomes actually in low-risk patients. And are you aware, because my knowledge of maybe all this literature is not as firm, of their safety profiles too? Like, were they safer than the control regimen? And do we really, in MDR-TB, we did IPD analyses of tons of programmatic data to make recommendations. And here we have clinical trials, several of them with people with similar phenotypes. Anyway, how do we apply these things moving forward?
Yeah, no, I think that's clearly the very important question. Like, clearly to start with, if we go shorter, with like all the clinical trial regimens were like, I would say they contain pyrazinamide, they contain rifampin, so all of these drugs that isoniazid that basically are guilty of side effects, right? Pyrazinamide and isoniazid. So if you think about alternative regimens, we don't really have sufficient data on alternative regimens that not contain pyrazinamide and isoniazid, and rifampin as well. I think rifampin is causing a number of issues. I think one thing we could do, and we have learned, I think clearly like shortening treatment will help because clearly you're cutting off 2 months of HR, and we do see that some of these clearly side effects that do happen later in the regimen, later. So it's not all like early on. So I think that's definitely going to help, and we can quantify how much. I think the other thing we've learned, which also can be implemented to in US setting, we've learned that, for example, you don't need to be given such a high pyrazinamide dose. And there's like a really nice evidence for study 31 that you can, if you want to still go for 6 months, you can lower pyrazinamide dose down to 1200. For example, or a gram, 1 gram or 1200. Clearly, that's not recommended dose. It's not in the guidelines, but you're not really losing efficacy if you still want to go for 6 months, and that will definitely improve the safety. I think there's a really nice relationship how much you can improve safety while still maintaining the efficacy by kind of cutting 400 500 milligrams from pyrazinamide. That's another thing that can be done on the safety side. And I think on INH, clearly, I think, INH is the drug that started pharmacogenomics field, and, but we still don't really account for that. And if we can dose better based on genotype, again, that's something that we could do in US setting, because we can get a saturator test and clearly give people what the dose they need. I think the safety, what we can do with current regimen is really based on the dose and dose adjustments, so patients can get truly what they need while managing the side effects.
Thanks, Radha.
Can I ask a related question? I was wondering about adverse effects, because it came up as a strong theme, I think, for the NAR conference, and work by Bill Berman and others made me reflect on it after the conference. In your looking at your slides again, I saw that the periods, I think if I'm remembering this correctly, the PZA dose was 1500 in several of those arms in the trial. So based on what you said now, is there how do you plan to deal with side effects if people have them on that dose? Will there be is there a stratified approach to dealing with adverse effects? And also, one of the other big issues that came up was about a lack of inclusion of populations that we see in practice, like older populations, particularly in trials. And I wondered if you had thoughts on that too.
Yeah, that's a great point. So how did we learn about pyrazinamide that I just said? I think we were actually lucky because in study 31 was 2,500 people trial, and they have done weight-based dosing. So basically, there were a number of people receiving 1,200, number of people 1,600, number of people 2 grams. So clearly, almost double, twofold difference in the dose. And we do that because we think people need more because they're bigger, but actually they don't need more. There's no rationale to dose patients by weight, because the elimination rate is not faster if they're bigger. I think that's one of the old things we're still doing in TB, which is not needed. But because of that, so basically these people have comparable exposures, no matter do you receive they don't have comparable, but nevertheless, for the patients with comparable exposures, we've learned that you can go lower on the exposure and still kind of keep the same efficacy. So there's we kind of published the whole work, and it was really kind of tricky to tease out all of these things. But nevertheless, I think that the evidence is very strong from 2,500 people trial. Let's study 31. And I have to thank Andy, because he was a champion of pushing us to get PK data in all these patients, because without that, we would not we would not learn any of this. Yeah.
Okay, thanks, Radha. I've been told we're at time, so I'll thank you again for honestly a great presentation, very stimulating, a tour de force of, it feels like that's all come out very recently in my head at least, and just a ton of research, and yep, thanks for running it back. And I'll pass off to Ruvandi now to introduce Dr. Andrew DiNardo, another talk that I've heard so much about and I'm excited to hear.
Great. Hi, everyone. Really nice to see you all joining us for this webinar. I'm Ruvandi Nathavitharana. I'm an infectious diseases doctor and TB researcher based in Boston at Harvard Medical School. I'm really thrilled to introduce Dr. Andrew DiNardo. He's an infectious diseases physician at Baylor College of Medicine in Houston, where he co-leads the Ben Taub General Hospital TB clinic with Dr. Guy. He also spends 3 months a year in Eswatini studying how the epigenetics of host immunity regulates inflammation, affects post-TB cardiovascular disease and post-TB lung damage. And in recognition of the fact there's no single immune response to TB, which he's going to talk about, in partnership with Professor Christian Coaffa, Dr. DiNardo has been implementing unbiased bioinformatic analyses to define TB endotypes, which he's going to talk about with us today. Thanks very much for joining us.
All right, so we'll start by defining endotypes as distinct molecular perturbations that lead to similar clinical phenotypes and disease presentations. And I like to start with a little bit of history. So most of us know the story of 1882, when Robert Koch showed his meticulous data leading to Koch's postulates and the firm establishment of the bacilli, MTB, as the causative pathogen for tuberculosis. Now, approximately 10 years later, Koch announces to the world that he cured tuberculosis, and he developed his tuberculin, which in guinea pigs was able to arrest the progression of tuberculosis disease. Interestingly, he injected the tuberculin into himself as well as his fiancée. And in the newspapers, it was announced that we had a cure for tuberculosis. Now, unfortunately, as meticulous as Koch was in terms of establishing the microbiologic etiology of tuberculosis being the pathogen, he was unfortunately very sloppy in the clinical trial evaluating the tuberculin for the treatment of tuberculosis. And while some individuals did improve, unfortunately, many individuals who received tuberculin died. Now, interestingly, Virchow, who the apocryphal story goes that Virchow was quite upset and frustrated with Koch's announcement of microbiologic announcement of the pathogen MTB as the causative agent, because Virchow believed that all disease was histopathologic in nature. Now, 9 years later, Virchow is still the famous pathologist, and it's Virchow who does the autopsies of the individuals that died after receiving tuberculin. And what he described is clearly what we would now call fatal immune reconstitution. There was this eruption of irritating arachnoiditis, intense hyperemia, a fresh crop of tubercles popped up after the injections. And a couple of interesting points here. So first of all, we have what seems to be the first described immune reconstitution, but he's also saying, look, we see it does work sometimes, but other times it was clearly pathologic, leading to clinical demise. So the other thing that we can see here is that tuberculosis morbidity and mortality is clearly not only due to the bacilli, but the host immune response. So problem number one is we don't have a single immune correlative protection. And fast forwarding the immunology a couple years, what I'm going to show in the next couple of slides demonstrates that what we see to be protective in vitro can actually be fatal in vivo. So in the 1970s and 1980s, we started identifying critical cytokines, interferon gamma and TNF. And by the mid-1980s, we knew a lot of things of what interferon gamma did. We knew that interferon gamma improved phytolysosomal maturation, that it upregulated worm metabolism, increased ROS, increased antigen processing, and it also was a chemokine. So at least in vitro, we knew that it improved intracellular killing of intracellular pathogens, but that it also attracted additional immune cells. A study published in 2013 by Daniel Barber from Alan Shearer's lab, what he did is when they identified PD-1 as an immune checkpoint inhibitor, he infected PD-1 knockout mice with MTB. And you can see here that the PD-1 knockout mice have an increase in interferon gamma. Now, unfortunately, that did not improve the immune response to MTB. In contrast, what happened is there was this massive influx of immune cells into the lungs that killed the mice. There's a similarly interesting story in TNF, and this is a fascinating story. It started with work by David Tobin, came out of Lolita Ramakrishna's lab. And it started with a genetic screen of zebrafish. And what they found really fascinating in the zebrafish screens was in the leukotriene pathway, there was a SNP that they found that led to either too little or too much TNF. And over a series of papers, they found that too little TNF and the mycobacteria would live happily ever after inside the macrophage. Too much TNF and the macrophage would undergo necrosis and die and allow the mycobacteria to escape viable into the extracellular space. But they finished this story that started with zebrafish immunology with reanalyzing the famous dexamethasone studies for TB meningitis. And what they found here is that the individuals that had the genotype that had too much TNF benefited from the dexamethasone. And in contrast, the ones that had too little seemed to actually have done worse. So in summary here, we have data that too much interferon gamma led to dead mice. There was another study that was followed up on that first one. Again, PD-1 null knockout mice. Too much interferon gamma led to dead monkeys with TB. There was another study that looked at IRG1, which is a metabolic checkpoint. And again, if you infected mice with IRG1 null mice with MTB, there was an increase in TNF, interferon gamma, IL-6, IL-17. Unfortunately, that led to increased immune infiltration into the lungs and more dead mice. And there's probably evidence that the same thing, something similar happens in humans. And there was a clinical trial that was stopped early in which aerosolized interferon gamma was given to MDR patients. And again, the study was stopped because there was an increased rate of death in the humans who received interferon gamma compared to those who didn't. So in summary, what we think, the model that we're working with right now, is that there can be deficient TNF, interferon gamma immune response, allowing MTB to survive intracellularly. You can have too much interferon gamma and TNF, and then the macrophages undergo necrosis, and the viable MTB escape into the extracellular space. And you kind of need this just right amount of interferon gamma and TNF for MTB clearance. And so that's leading us to this thought that you can have different, and in this case, contradictory, molecular endotypes that can lead to a similar clinical phenotype. Before we moved forward with the next step, we wanted to try and document as many different TB endotypes as we could from the literature. For those of you who have other ideas, please share them. We're documenting this, but we wanted to have something written down before we did our next phase of analysis, which was an unbiased approach. Before getting into the analysis that we did, I just want to review that this is not something out of reach, and that there are other diseases that have already taken this endotype approach in order to, for asthma, regularly treat asthma via endotypes. But for cancer, the endotype approach has resulted in improved therapy and improved survival. So we have standard of care for asthma, endotype-based standard of care, and we have endotype-specific treatment that's been documented in different forms of cancer to improve mortality rates. This is also being developed for both COVID and non-COVID induced ARDS, that there is a hypoinflammatory and a hyperinflammatory endotype that differentially affects survival. And then a early phase clinical trial that you could treat sepsis endotypes, either based on an overactive macrophage activation-like syndrome in which you would give anakinra, or an immune paralysis syndrome that you would treat with giving recombinant interferon gamma, and then you would have an intermediate phenotype that could be left alone. And so further studies are going on to evaluate endotype-specific therapy for sepsis. Here's the endotype concept in asthma, that there that a similar clinical phenotype can be driven by allergic asthma or eosinophilic asthma or neutrophilic asthma or a polygranulocytic asthma, and that each of these would require distinct therapies. In terms of leukemia, in 2008, 2013, there were different mutations identified to be driving leukemia. In particular, FLT3, DNMT mutations, or IDH mutations. From 2013, 2018, they had identified that an IDH inhibitor would improve clinical outcomes in AML patients who had IDH-specific AML. Similarly, they identified that a FLT3 inhibitor could be used for FLT3-specific AML. And then they identified that BCL2 inhibitors, venetoclax, could improve leukemia. So in a very short period, 3 new FDA-approved drugs were identified that improved standard of care and improved survival. Here's what the treatment algorithm for leukemia looked like in 2017. And here's what it looks like now in the era of molecular endotype-specific therapy. Here's the unbiased approach that we took to begin to identify some evidence for TB endotypes. We started with data mining different transcriptomic studies that were publicly available. We implemented an unbiased Seurat clustering. And depending on the resolution that we looked at the lowest resolution, we saw 2 endotypes, and obviously there were more endotypes visible at higher resolutions. This data was validated with 2 unique RNA data sets. It was also validated with the data set of TB patients from Germany and Romania that had additional clinical information. We were able to do some validation from an Eswatini immunology cohort. And then finally, we linked the data to LINCs, Library of Integrated Network Connections, to look at how different host-directed therapies would work with the different endotypes. What you can see here is that endotype A enriches more for pathways associated with interferon, heme, inflammatory, TNF, and IL-6 pathway. Endotype B also enriched for these pathways, but not as much as endotype A. In contrast, endotype B enriched for pathways associated with metabolism and cellular proliferation. You can see that data here. You can see a stepwise increase from the healthy controls to endotype B to endotype A for pathways associated with inflammation, interferon gamma, IL-2, hallmark, complement, coagulation, and TNF. In contrast, what you see when it comes to metabolism proliferation is that there's an increase in endotype A and a decrease observed in endotype A compared to the healthy controls. When we looked at this in terms of its relationship to clinical outcomes, we identified in the Romanian cohort that the deaths occurred in endotype A, and obviously it's a small number in this cohort. And we also saw that the endotype A had a slower time to culture conversion. We connected the endotype signatures to different host-directed therapies using the LINCs database. And what you can see here is that host-directed therapies that might be beneficial for one endotype were either inconsequential or potentially detrimental for the other endotype. Okay, fair enough. Transcriptomics is not clinically relevant. So how can host immunity and inflammation be assessed now? And the next couple of slides are not evidence-based. And in the next couple of years, I hope that some of these develop evidence and we can identify how to properly evaluate inflammation and immunity. One simple way is using CRP or ESR to check for inflammation. This is data from Eswatini demonstrating that, and similar to what other cohorts have shown, that despite successful therapy for TB, many TB survivors do not normalize their inflammatory pattern. Potentially, this is a way to identify TB survivors that are increased risk for post-TB cardiovascular disease. The other thing that's feasible in some cases is evaluating a cytokine panel. So for example, in the United States, the CT that I just showed was a lady who had pulmonary TB and 2 months later developed seizures and was found to have paradoxical iris with a CNS lesion. We checked a ARUP cytokine panel on her. She had very high levels of IL-2 and responded to dexamethasone. We do not have the evidence right now to state that just because you have high IL-1 beta, that anakinra is the right host-directed therapy for you. But at least we do have a way to start documenting this. And for some sick individuals, this in the United States, compared to the cost of being in the hospital, this is not a major price increase. This is a publication of a case series in which individuals who had paradoxical immune reconstitution in the Netherlands, who did not respond to steroids, then did respond to anakinra. Here's some of a CT of one of the individuals who, again, was not responsive to prednisone, but then did have a clinical improvement on anakinra, the IL-1 inhibitor. Another thing that's feasible to do right now is using the quantiferon, and not using the quantiferon to look at their TB1 response, but using their quantiferon to look at their nil and their mitigen value. So anecdotally, when I have individuals that have a nil quantiferon interferon above 1, those are the individuals that I found to be extremely high risk for immune reconstitution. And the numbers that I'm showing you is a gentleman that had paradoxical iris inducing a duodenal perforation. And you can see 2 months into therapy, the baseline nil interferon gamma level was above 3 and above 4. And this individual needed immune suppressive therapy to prevent his pathologic iris. You can see, in addition to being hyper-inflammatory with the very high nil interferon gamma levels, he had very low mitigen-induced interferon gamma levels, so that he was hyper-inflammatory but hypo-responsive to stimulation. Here's something else that can be done, and we do this every couple times a year. We had an individual that had very severe spinal TB. It was a college student from Vietnam. And his PBMCs in the setting of controlled plasma, you can see a large increase of interferon gamma and TNF after his PBMCs were stimulated with mitigen in the setting of healthy controlled plasma. In contrast, in the setting of using his own plasma with his mitigen, you can see a very small amount of interferon gamma and TNF upregulated. And what we found, and we sent his blood to the NIH for confirmatory testing, is that this individual had a very rare autoantibody syndrome where his body was producing autoantibodies to interferon gamma. Okay, these are extreme cases. So how does this apply to regular garden variety tuberculosis? So I'll make an argument that TB is not fully curable with antibiotics. And when we have a microbiologic cure, that does not mean that health of the individual has improved. We know this because if you look at the epidemiology of TB survivors, they have a 3.7-fold increased risk of all-cause mortality. It's specifically with an increased risk of cardiovascular disease, cancer, respiratory disease, and secondary infections. We know a large number of TB survivors have permanent lung damage, 15% with severe lung damage, 50 to 75% with mild to moderate lung damage. Here's a paper from Julie Critchley that looked at the rates of cardiovascular disease among the US VA cohort and then UK cohort, showing the high rates of cardiovascular disease before, during, and after diagnosis for tuberculosis. This is a chest x-ray and spirometry of what we hope to happen. There's a large cavity here, and during antibiotic therapy, the cavity shrinks and the lungs dramatically improve and spirometry gets better. But plenty of times, we also see no improvement. You have this fibrosis and this scarring, and by the end of therapy, the fibrosis and scarring isn't dramatically improving, and the spirometry stays poor in this individual. You also have cases where you have a paradoxical worsening and the lungs get worse despite successful antibiotics. We reanalyzed Dr. Wallace's published data from his 2021 clinical trial. And like other reports, around 10 to 20% of TB patients are going to have worsening lung function despite successful antibiotics. So problem number 2 and problem number 3 is that antibiotics don't resolve inflammation and they don't resolve allergy. Here's the data that was published from a previous clinical trial that Dr. Wallace ran. And you can see I added this red dotted line, which is where CRP is supposed to be below. And individuals with a CRP greater than 3 have increased cardiovascular disease. And you can see that the majority of TB patients, despite successful therapy, have persistent inflammation. We see the same thing in Eswatini, which more than half of the TB patients who were successfully treated with antibiotics have persistent inflammation. This was a previous study from Indonesia, and again, I added the red dotted line. What you can see here on the left is TB-induced IL-12 production and mitogen PHA phytohemagglutinin-induced interferon gamma. And in both cases, at the end of therapy, more than half of the TB patients still are not as immune responsive as healthy controls. Here's some preliminary data where we looked at the TB endotype signatures, so healthy control, endotype B, and endotype A. And you can see here that the gene activity scores for diseases related to cardiovascular disease, myocardial ischemia, cerebral ischemia. We looked at 2 different cancers, non-small cell lung cancer, leukemia. All of these are increased risk in TB survivors. It looks in these 4 cases like endotype A, it has the highest risk. Asthma was the outlier where endotype B had a higher risk. And then idiopathic pulmonary fibrosis also increased from healthy controls to B to A. So in summary, and the unanswered questions we have, we know that there's multiple TB endotypes. However, we don't know which of our TB patients who are in front of us need immunosuppressive or immunoactivating host-directed therapy to improve their outcomes. We don't know which TB endotypes are suitable for only 2 or 4 months of antibiotics. We don't know which TB endotypes are at risk for post-TB cardiovascular disease or post-TB lung damage, and how to apply endotype-specific host-directed therapy to decrease those risks. Thank you.
Thanks so much, Andrew. That was a fantastic talk. Really, really appreciate your your research and insights into sort of how we can actually do better in terms of clinical care now. Nothing in the chat yet, but please do come forward with questions. I guess in the meantime, I'll say I wrote to you actually after the conference because we had a patient with TB meningitis, and actually inspired by your talk at NAR, I really hoped that the team would be able to send a cytokine panel. Unfortunately, because that patient basically was having a very slow response to TB treatment, actually, sorry, had a slow response radiographically to TB treatment. Clinically, actually, that patient had improved remarkably given his burden of disease. But the neurology team had been, I think, very quick to go down on his steroids, which I was concerned about. And I actually I was wondering about whether that patient, because his MRIs looked so abnormal and had worsened even during treatment, whether he'd be someone who would benefit from immunomodulation and how we might choose. In the end, I don't think it ever got sent. He seems to be clinically improving and is transferred care to a TB clinic closer to him. But it made me think practically about how we could be using some of this knowledge in our clinical care. I wanted to ask you a question about what do we know about how TB endotypes vary in people with higher risk for TB, like people with HIV, and then also people with diabetes or any other groups that you might think of?
Yeah, unfortunately, the study that I showed and the data that I showed was data mined out of GEO, which is an excellent public database, but does not have a lot of metadata. I'd say around half the studies mentioned HIV. All the studies had sex. None of them were linked to quantiferon or a T-spot, quantitative values. And none of them had diabetes, none of them had CD4 count or viral load. At least in our preliminary analysis, we do not see major differences in endotypes based on HIV, but we need to look at CD4 counts, HIV viral load. Almost everybody is getting integrase inhibitors now, so I don't know if we'll be able to look. Is there a difference between PIs and integrase inhibitors? More to come, and we have to figure out how to get that research done.
Yes, yeah, and I wonder also in the at least some subset of the people that we care for with TB in the US have TB or increased risk of progression because of immunomodulatory treatments. So you wonder how endotypes may vary in those groups who have received some kind of immunomodulation, and they may be the ones who are at higher risk. Who, or one of the groups at higher risk.
It's embarrassingly how few immunologic assays have come to market that we on a day-to-day have available clinically, and we need to be able to assess that. I know some fields are now have, for example, if you get a CAR therapy for your cancer, you're going to get a weekly IL-6 level, and we need to get to that level where clinicians are comfortable looking at IL-6, TNF, IL-1 beta levels and interpreting them and knowing how to apply them to therapy.
When you see, we're hoping that others will have questions in the chat. I'm wondering, another question that I was thinking about is when you showed your slide about the paradoxical worsening, and maybe if we think about the people without HIV, or perhaps with and without HIV, do you now, because of your research, have a different approach to when you see people with paradoxical worsening? Are you more likely to get these sort of cytokine assays at that point to think about how to approach treatment?
Yeah, well, so I see a skewed population here in Houston, and here in Houston, we manage the severe cases. So almost everybody that we see qualifies for getting therapeutic drug monitoring because they have a large cavity, because they have extrapulmonary disease, because they have a malabsorption syndrome or diabetes. So a week to 2 weeks into starting their TB therapy, we get therapeutic drug monitoring, and I know that their drug levels are where they're supposed to be. So if they have a paradoxical reaction, I have a very low threshold for starting immunosuppressive therapy. And we've had 2 people that didn't respond to immunosuppressive therapy that I worked both in the with CNS disease that I worked with the neurologist to get infliximab, and they did well. So I have a very low threshold once I know that the antibiotics are, that they're right, that we don't have drug resistance, and that we're getting the right levels of antibiotics into them. And then I usually do it simultaneously. I empirically start a steroid and check a cytokine level, looking to see if it's very high for IL-2, they usually respond to steroids. And if not, do we have to try something else? And then fight with the bureaucratic nonsense to get the monoclonal inhibitors. There's one here about the compartment. Does it matter blood versus sputum? And I don't think we know. I think there's I've seen some cool technologies out there that we could potentially be able to look at cytokine and inflammatory levels from exhaled breath, which would allow us to answer that question. And that technology needs to get better. The next question, what should be the ideal rifampicin dose for TB, 10 or 20 milligrams per kilogram? We have large numbers of post-TB lung disease in India. Well, so I think there's 2 questions in here. We start everybody in Houston on 20 milligrams per kilogram, but there is, based on the drug-drug interactions with rifampicin, it's if you had coexisting steroids, you're going to reduce the metabolites a little bit with that. But I almost always give 20 milligrams per kilogram, and I think Radha would be better at answering this question. The connection to post-TB lung disease, we need more clinical trials evaluating if NAC, metformin, everolimus are able to empirically be given for individuals with post-TB lung disease, and identifying again, there's at least one good study that IL-6 and some other neutrophil markers, biomarkers, can predict PTLD so that we can identify who needs those therapies. What I know about for signatures that predicts PTLD is IL-6, alpha-1 trypsin. There's a marker called SITH3, which is a marker of netosis from neutrophils that have mild evidence for predicting PTLD, but I wouldn't call any of those excellent studies. I think they need to be validated and a lot more evidence there.
And the CRP data that you presented as well, because that's something, not everyone gets a post-treatment CRP or any follow-up CRPs, but it does make you wonder, should we be with what we know now, should we be triaging those people for different follow-up post-treatment completion, perhaps? See some hands up. Dr. Vernon?
Thank you. Thanks. Great talk, Andrew. What are you thinking currently about the immunologic perturbations early in TB meningitis, when most of the bad outcomes are determined?
Right. And the evidence for steroids is that they prevent neurologic progression, but that they don't reverse neurologic progression. So there's a good argument there that we need to be improving our diagnostics. I saw data at a conference on Reinhard van Crevel presented data on TB endotypes in specific to meningitis using proteomic and metabolomic data. And I'm hoping that story gets published soon. Based on what we saw with sepsis, I'm assuming that there are a subset of patients with TB meningitis that have immune paralysis and might need something like recombinant interferon gamma, while there's a subset that need more than just dexamethasone, that need anakinra or infliximab right up front, not waiting for the dexamethasone to fail. So we have to figure out how to get those studies done in the setting of decreased funding.
Rachel, I think you have a question too.
Yeah, just wondering if any of your data included children, and what your thoughts are there. You know, I see a lot of mediastinal disease, but then sometimes it's really bad, and I see parenchymal disease, and probably changes over time with age. And for those of us who don't have access to that panel, what would be your kind of suggestions in terms of just basic blood work to kind of figure out an endotype, or is that possible?
You can lie, but I don't think it's possible yet. It's one of the major things that we would like to do. Is we know that transcriptomic signature is never going to be possible. It's why I'm so fond of the study by Sinna and O'Donnell that I mentioned earlier on ARDS associated endotypes, because they used almost all clinical features, albumin, D-dimer, ferritin, in order to identify the endotypes. We know we have to do something like that. It just needs to be done. And we're applying for funding to try and get it done and trying to do the work in other ways as well. Specific to adolescents, I suspect adolescents are going to be different than adults, and kids are going to be even more different. I hate to be a broken record, but give somebody the funding. Don't give me the funding. Give somebody the funding so we get it done. I just don't know that I don't think the data is out there. We couldn't find it.
And you mentioned the quantiferon quantitative values and the T-spot. How do you we switched recently to the T-spots, so I'd love to know your thoughts on that. And also, you know, how could, like, it seems like maybe with the tools, having that test, CRP, burden, and I guess burden of disease I was thinking about from Radha's talk, but what could we be do differently in terms of trying to predict who might be at risk of sort of worse outcomes both during and then post TB treatment?
I hope somebody develops that evidence. Right now, because my hospital has a robot, so we can do the quantiferons very easily. again, if I see a very high nil response, I know they're hyperinflammatory. That correlates very well with CRP, SED rates, white count, and the monocyte to lymphocyte ratios. I have a very low threshold for starting some sort of immunosuppressive if their quantiferon nil is above 1, or especially if it's 2, 3, or 4, which we'll see a couple times a year. I just don't think you can do that with the T-spot because of its semi-quantitative nature. I think that's a little too challenging. So I don't have a good answer there.
Yes.
Okay, well, I think that concludes our session slightly early. I would like to give a big thanks to all of our speakers and moderators, as well as Curry Center for organizing this. And again, thanks to everybody for supporting the North American Region Union section. This is mostly volunteer-based and people doing it. Oh, Andrew, do you have another question?
Sure, I'll throw
Right at
another
the
one.
last minute? Yeah.
Yeah, just out to Andrew. You commented on the fact that there's not enough understanding of how these biologics ought to be used and the different endotypes that may require different drugs. Why do you think that communication gap exists? Normally, the community is fairly prompt to adopt novel therapies that establish, for which effectiveness appears well established. So over time, I have looked periodically for cogent articles that will update me on my understanding of immunology, because it's been a long time since I actually studied it, and it's difficult to find. There's a communication gap, and I wonder what your thought about it is.
I think that's part of the answer right there. Is the field has gotten, over the past 10 years, we've switched from smear and culture, 150-year-old tests, to molecular PCR. So we're making advances. I'm not complaining that we're not. But we haven't had a clinically relevant immunologic new test, in over 50 years, except for the quantiferon and the T-spot, and they were brought in as a binary yes, no, not as the quantitative nature, which I would like to see them used. So I think there's a very large gap between mouse models of immunology and clinical immunology that can be done right now, and that gap needs to be closed. But I think it took the cancer field, which has a lot of private funding, 10, 15 years to go from identifying molecular subtypes. The TCGA, the Cancer Genome, which was a NIH-funded large database to collect this information for cancer, has touched every single type of cancer. Breast cancer is different treatment based off of what the TCGA was able to find. We don't have anything similar in TB, where you have extremely large clinical cohorts, which large multi-omic studies and clinical data to back that up. So the TB portal is moving in that direction. Geo certainly helps, and there are some other data sets there. I think we're getting closer and moving. I think the PTLD field is clearly demonstrating that inflammation is bad, and we need to be thinking about biomarkers for inflammation. And I think the field has clearly moved of, hey, just because you kill the bugs, that's not sufficient. So I think we're making progress. Hopefully that was a good enough answer.
Well, what I'd like to see is a bit more of a design for immunologic add-ons to trials that are underway. By and large, they've mostly been sort of scatter shots up to now, and something that's a little better targeted that would give us some additional information to use in therapy would be welcome. But
that's a great point. I'd like to go back and ask you. So let's say all of these clinical trials that are being done, and there's a slew of large clinical trials currently being implemented. I'm going to guess that in most of them, the funding didn't include biomarkers and certainly not biomarkers to look at immunity and inflammation. I bet you they're all looking at how quickly you can become culture negative, which if you're a TB patient, do you care if you're culture negative a week or two later if your breathing stinks?
Well, I think the response to that is it's taken about almost 20 years, but PK measurements have now become more or less de rigueur in in most TB trials because people have finally been convinced that you can do something with those data. Um, the I think we need the same thing in this area of immunology and the immunologic uh, phenotypes that with which you're very much engaged. But we don't have that yet. We don't have even the design for that yet.
I think,
And
I think that's a really interesting statement in general for infectious diseases. Certainly, I think there's more research, or at least COVID prompted more interest in immune responses
Mhm.
to infections. And I think generally the field is probably going that way, but maybe at its infancy, I would suggest.
Yeah,
So I think on that note, we'll
thank
end
you.
our session. Thank you, Dr. Vernon.
Thank
Um,
you. Thank you
and
all.
again, thanks again for everyone's efforts. This is purely a volunteer activity for TB enthusiasts, as I always say. And we really, really thank everyone who came to support the NAR organization again, and the continued support of our activities. And please think about coming to our conference next year in Philadelphia. It will be in February. And again, we really want to encourage people to continue to support the TB community in these challenging times. And the NAR organization, which is responsible for these activities and the conference, how we get money and put on these conferences, it's a nonprofit, but it's by attendance. So we really, really would encourage your attendance in the Philadelphia area. Um, and with that, I'll conclude. If you could give everyone a virtual round of applause. And with that, thanks so much and have a great afternoon.